طيب، مساء الخير ومرحبا بكم جميعا في الويبينار. الليلة حنتكلم عن البريست كانسر ميميكرز. كان الأسبوع اللي فات بدينا في نفس التوبيك وتكلم الدكتورة سلوى من الجانب باثولوجي، ومفروض كان إنه نكمل المحاضرة بتاع الدكتورة سلوى، بس لظروف خارج عن إرادتها فحتكون المحاضرة يعني rescheduled إن شاء الله the rest of it. Today we are going to be talking about the breast cancer mimickers from a radiological point of view. Mimickers of breast cancer are conditions that are clinically, radiologically, or pathologically resemble breast cancer. Certain benign conditions share similar features to malignant tumors in terms of their radiological appearance, leading to challenges sometimes in accurate diagnosis. Accurate differentiation is crucial to avoid unnecessary biopsies by pathologists or surgeries, and at the same time, ensuring that true malignancies are not overlooked or missed. Breast cancer mimics are either benign conditions resembling breast cancer, or could be malignant conditions resembling benign tumors or distant malignant conditions metastasizing to the breast and mistakenly diagnosed as of breast origin. The benign mimics benign inflammatory conditions such as infectious mastitis, breast abscesses, granulomatous mastitis, lymphocytic mastopathy, which is also called diabetic mastopathy, and breast cellulitis. It is also containing proliferative breast conditions such as fat necrosis, stromal fibrosis, sclerosing adenosis, and radial scars. Also benign tumors such as hamartomas, inflammatory intramammary lymph nodes, pseudoangiomatous stromal hyperplasia, tubular adenomas, desmoid fibromatosis, granular cell tumors, fibroadenomas, phylloides, and papillomas. So these are the benign mimics: benign inflammatory conditions, proliferative conditions, benign tumors. As for the malignant mimics, these are mistakenly labeled as benign. هم أساساً هم malignant لكن are labeled as benign by mistake. They are either originating from the breast itself, such as low-grade DCIS, or inflammatory breast carcinoma, or low-grade angiosarcoma, mucinous or papillary breast cancers, or originating elsewhere in the body and metastasizing to the breast, such as from metastasis from melanoma or renal tumors, gastric and lung cancers. The diagnostic tools that we rely on in order to accurately diagnose breast masses comprise a wide range of entities. The most important one is the clinical history, where we review the patient demographics, history of trauma, history of infection, diabetes, any history of prior surgery or previous similar condition within the same patient, or any positive family history. Imaging stability. By this, we mean to compare the current images with other previous studies, if available, and see how is the tumor is progressing through time. Multimodality correlation. By this, we mean correlating the mammogram findings to the findings from ultrasound and MRI. And biopsy, which is the definitive diagnosis, is, if required, is done to eliminate the dilemma. Accurate diagnosis, as we said, often requires a combination of all these tools to avoid the misdiagnosis. We're going to be starting with the benign inflammatory conditions. The benign inflammatory breast conditions constitute a heterogeneous group of breast conditions characterized by a marked inflammatory process. These conditions are clinically important because they closely mimic and are often clinically and radiologically indistinguishable from the inflammatory breast cancer. Biopsy is usually indicated to establish the correct diagnosis and to rule out breast cancer. To start with, we are going to start with infectious mastitis and breast abscess. The breast abscess is a complication of infectious mastitis, or a consequence of infectious mastitis. Abscesses can be associated with lactation in the case of peripheral abscesses, or independent of pregnancy in the case of non-purpural abscesses. The purpural abscesses tends to be peripheral in location and are often easily recognized clinically. The non-purpural abscesses can pose a diagnostic challenge and are more commonly seen in older women. Non-purpural abscesses are usually periareolar and typically have worse outcome and a higher rate of recurrence than purpular abscesses. The risk factor for non-purpular abscesses are thought to be including smoking and diabetes, among others. Clinical presentation, in this case, clinically, the breast will be indurated, red and painful. The nipple retraction may also be evident. There might be nodal enlargement. Patients may often have systemic symptoms such as fever or leukocytosis. When we come to the radiographic features, mammographically, mastitis and breast abscesses present with skin thickening, asymmetry. It could present as a mass or architectural distortion. Sonographic features of breast abscess include one or more hypoechoic collections of variable shapes and sizes that are often continuous and multiloculated. Breast abscesses typically demonstrate a thick echogenic rim and increased vascularity, which might be mistaken for malignancy, and hence comes the dilemma. Associated mastitis presents as an area of increased parenchymal echogenicity, representing inflamed granular parenchyma around the abscess. Skin thickening, distended lymphatic vessels, and inflammatory axillary adenopathy can also be seen in the same case. This is an image of the left breast. It shows diffuse, relatively ill-defined echogenic breast fat tissue and increased color Doppler flow. I will show that in the next slide. Besides enlarged axillary lymph node, which will appear also in the next slide. There is no evidence of skin thickening or focal skin thickening or retraction, and there is no masses. There is dilated lactiferous ducts, but without evidence of wall thickening or internal echogenic component or debris. This is a mammogram of the right breast. The right breast is heterogeneously dense, which could obscure small abscesses if found. In the upper outer quadrant of the right breast, there is a big oval mass with obscured margins and density equal to that of the fibroglandular tissue of the breast. There are also several axillary lymph nodes seen. And the ultrasound of the same patient shows a hypoechoic collection with no vascularity within the abscess and shows posterior acoustic enhancement. As inflammatory breast cancer is the most important differential here, with this clinical presentation, caution must be exercised to exclude any underlying malignancy. The patient with a clinical presentation typical of a breast abscess requires a short-term, that is around 7 to 14 days follow-up of short-term antibiotics, short-term course of antibiotics with 7 to 14 days follow-up after the treatment and drainage. Inflammatory breast cancer should be strongly considered in patients with breast erythema and swelling in the absence of an abscess on ultrasound evaluation, especially in older non-lactating patients and in patients who are at increased risk of breast cancer due to any cause. Mammography is indicated in these patients and should not be delayed. In lactating patients, although the mammography is initially delayed until the acute symptoms of the mastitis resolve following the course of antibiotic, mammography is still indicated where there is a clinical suspicion of malignancy, and in those with prolonged clinical course that does not respond to treatment. Although mastitis and breast abscesses can be difficult to distinguish from inflammatory breast cancer, a number of imaging features tend to differ between them. So you could use these to distinguish between the two. So while the skin thickening associated with inflammatory breast cancer is likely to be diffuse, the thickening associated with breast abscess and mastitis tend to be localized or focal to the area involved with mastitis. Suspicious microcalcifications are the most specific finding in the breast cancer in patients with inflammatory breast symptoms of unclear etiology. You won't find that in the mastitis and breast abscess. A mass with a hypoechoic wall and associated interstitial fluid is more suggestive of a breast abscess and not usually seen in the setting of cancer. Ultrasound evaluation of the axillary lymph node in cases where malignancy is the primary consideration is more likely to show markedly abnormal lymph node enlargement with the characteristic cortical thickening and higher displacement of metastatic lymph node. While in contrast, the breast abscesses are more likely to be associated with reactive lymphadenopathy characterized by mild diffuse cortical thickening. In patients with prolonged course and patients whose condition does not respond to antibiotics, breast biopsy is indicated and should not be delayed. This is a mammographic image for a breast abscess that was mistaken for breast cancer, and biopsy revealed that it was a breast abscess. We have a case of a 45-year-old woman presented with palpable area in her right breast. The mediolateral oblique mammogram shows a focal asymmetry in the upper outer breast. Power Doppler ultrasound images reveals two hypoechoic oval lesions or masses with peripheral vascularity in the same region. The axial post-contrast T1 weighted MRI and sagittal T2 weighted MRI and post-contrast subtraction T1 weighted MRI shows two T2 hyperintense rim-enhancing masses. And when needle biopsy was done, it showed acute inflammatory cells consistent with abscesses without evidence of malignancy. That was all about the infectious mastitis. When we come to the granulomatous mastitis, granulomatous mastitis is a rare breast inflammatory disease of unknown origin that can clinically mimic breast cancer. The condition generally manifests as a distinct, firm to hard mass that may involve any part of the breast, with the subaerial region being relatively spared. The relationship of granulomatous mastitis to the pregnancy or lactation state has been strongly emphasized because this disease entity typically affects younger women, usually within the period of 6 months to 9 years of pregnancy. It can happen anywhere between these times. Pathologically, it is characterized by a non-caseating granulomatous inflammatory process of the breast lobules without an identifiable infectious or inflammatory etiology. Fat necrosis, abscesses formation, and fibrosis are commonly associated end-stage features of this entity. The granulomatous mastitis is a rare diagnosis of exclusion. Regarding its radiographic features, when it comes to mammography, granulomatous mastitis can have a variety of presenting features such as masses or asymmetry or trabecular and skin thickening. In some cases, the findings are mammographically occult or normal. Sonographically, one or more, commonly multiple irregular hypoechoic masses have been described. These masses can sometimes be continuous and can appear tubular at other times. In other cases, ultrasound shows only parenchymal distortion with increased shadowing without a discrete mass. So it's a range of appearance. Associated skin thickening and edema have also been described. This is an MLO of both breasts that shows asymmetry in the size and density of the breast, showing increased density of the retioareolar area with skin thickening in the left breast. This MLO image for both breasts show few lobulated oval densities. There's no architectural distortion or suspicious microcalcifications or clusters of microcalcification. This is an ultrasound that shows ill-defined hypoechoic lesions containing internal echoes and posterior acoustic enhancement. Another one showing well-defined hypoechoic lesion with irregular margins, and hence comes the dilemma that could mistakenly put these entities in the place of being malignant. We have a case of a 34-year-old woman, postpartum, presented with a palpable left breast mass, diffuse breast swelling, tenderness, and erythema for several weeks. Mammogram and ultrasound were done. The bilateral mediolateral oblique mammography shows diffuse skin thickening and global asymmetry. Diffuse skin thickening, global asymmetry between the two breasts, and trabecular thickening in the left breast. Extended field of view grayscale ultrasound shows an ill-defined hypoechoic irregular mass. The color Doppler ultrasound shows increased vascularity, edema, and skin thickening. Because the clinical and radiological presentation of granulomatous mastitis is indistinguishable from that of breast cancer, core needle biopsy is indicated to establish the diagnosis. Once concordance of the biopsy result is established, granulomatous mastitis is traditionally treated with corticosteroids or surgical intervention, such as wide local excision of localized disease, or rarely mastectomy when the disease is extensive and resistant to corticosteroid therapy. In cases resistant to corticosteroid therapy, methotrexate could be used. In recent years, expectant conservative management is becoming the treatment of choice, especially in mild cases and younger women. Spontaneous resolution has been reported in about half of the patients. The prognosis of granulomatous mastitis is favorable, although some cases can be refractory to therapy and can develop significant sinus tract and scarring. That was all regarding the granulomatous mastitis. We're going to talk now about the lymphocytic mastopathy or diabetic mastopathy. Lymphocytic mastopathy is a prevascular and perilobular inflammatory process of the breast parenchyma initiated by the infiltration of lymphocytes. Clinically, it presents as one or more painless, mobile, discrete breast masses closely mimicking malignancy. Multicentric and bilateral involvement is frequent in this case. In most cases, lymphocytic mastopathy is associated with diabetes. It could be come without diabetes, but most of the time it is associated with diabetes. However, other autoimmune disorders such as Hashimoto's thyroiditis, Sjögren disease or syndrome, and systemic lupus erythematosus have also been associated with lymphocytic mastopathy as well. Lymphocytic mastopathy has also been described in the absence of an underlying systemic condition, as we said, and when it's associated with diabetes, it is often referred to as diabetic mastopathy and is most often seen in patients with a long-standing history of insulin-dependent diabetes. It has also been described in men who have gynecomastia. When it comes to its radiographic features, in mammography, lymphocytic mastopathy presents as an ill-defined mass or asymmetry. On sonography, it frequently presents as a hypoechoic, irregular mass with posterior acoustic shadowing or an area of shadowing without a discrete mass or an obvious mass. Increased vascularity can be seen. The process is usually self-limiting, but recurrence has been reported in patients who undergo surgical excision. Therefore, close clinical and imaging follow-up is indicated to ensure that there is no interval development of new breast masses. We have a case of a 56-year-old lady presented with bilateral palpable breast masses and an 8-year history of type 2 diabetes. The bilateral craniocaudal mammogram shows bilateral non-calcified obscured masses correlating with the palpable mass in the patient. And the grayscale right and left breast ultrasound shows irregular hypoechoic masses with posterior acoustic shadowing. The power Doppler ultrasound demonstrated internal vascularity involving these masses. When core needle biopsy was done in both breasts, it revealed perilobular lymphocytic infiltration. A repeat core biopsy 8 months after the initial biopsy showed chronic lymphocytic lobulitis. There was no evidence of malignancy, and findings are consistent with diabetic mastopathy all through the way. Another patient who is 37 years old presented with right breast palpable retroareolar mass, swelling, erythema, and tenderness. The craniocaudal and lateral mammography shows a focal asymmetry and skin thickening associated with the triangular palpable marker in the lateral breast, if you can see it. The grayscale and color Doppler breast ultrasound reveals multiple retroareolar vascular masses. The core needle biopsy again showed acute and chronic inflammation and granulation tissue, and the diagnosis of diabetic mastopathy was put. The patient's symptoms resolved within a month. The patient presented 2 years later with contralateral palpable breast mass and nipple inversion. The craniocaudal and lateral mammographic views revealed a focal asymmetry in the central breast associated with palpable marker. The grayscale and color Doppler breast ultrasound reveals a vascular heterogeneous mass. And again, when the core needle biopsy was done, it revealed a benign breast tissue with lymphoplasmacytic infiltrate. No history of diabetes was found in this patient, and the patient's symptoms improved over the following 6 months. When we come to talk about the proliferative breast conditions, we're going to start with the fibrocystic changes. Fibrocystic changes of the breast, also known as diffuse cystic mastopathy, is a benign alteration of the terminal ductal lobular unit of the breast with or without associated fibrosis. It is seen as a wide spectrum of altered morphology in the female breast, ranging from innocent masses to those associated with an increased risk of developing carcinoma. They are observed clinically in up to 50% of women and histologically in 90% of cases. These changes are most frequently diagnosed between the ages of 20 and 40, with incidence peaking around the menopause due to hormonal alteration with estrogen dominance over progesterone. They are either non-proliferative, like breast cyst and/or fibrosis, or proliferative, such as sclerosing adenosis. The radiographic features. In mammography, the breasts show heterogeneous and usually dense parenchyma with areas of focal asymmetry. Circumscribed or partially circumscribed masses may be present, reflecting cysts or cystic changes. There are teacup low-density round calcifications in multiple lobes present as well. You can see these focal asymmetry, asymmetry between the two breast calcifications seen in both breasts as well. The same thing is apparent here as well. When it comes to ultrasound, there is prominent fibroglandular tissue in the area of a palpable nodule. There is diffuse or no focal mass or mixed hypoechoic and hyperechoic echo pattern, indistinct margins. So this is the appearance on ultrasound. Prominent fibroglandular tissue of the breast over the area of palpable mass, diffused with no focal mass, shows mixed hypoechoic and hyperechoic echo pattern, and no distinct margins. It could also present as a small, mostly thick-walled cyst in the mammary zone that are oval or round with parallel orientation, circumscribed or lobulated, and showing posterior acoustic enhancement and are avascular. So you can see both.
هنا دي عمتك
Okay.
بعد لا رافة
The same thing is
كنت
shown here.
تعلمنا
Could you please mute yourself? We have a case of a 48-year-old female presented with a palpable breast mass. The spot compression tangential, mediolateral oblique, and craniocaudal mammographic views did not show any corresponding abnormality, but the grayscale and power Doppler ultrasound images revealed an irregular
أنا عندي
mass
ريكورد مسجل كده نشوفه ليه
acoustic shadowing corresponding to the palpable area the patient complained of.
كما بحضر ليه في هنا يعني
Background noise. Excuse me.
Dr. Safa, please close your mic. Core needle biopsy of the mass showed stromal fibrosis without any evidence of malignancy. Another case of a 55-year-old woman presented for focal asymmetry detected on screening mammography. The mammography showed an oval non-calcified mass with angular margins. And when the ultrasound was done, it showed a mixed echogenicity oval mass correlating with the mammographic finding. Ultrasound-guided biopsy yielded stromal fibrosis in this case. The fibrocystic changes mimics breast cancer when there are clusters of microcalcification or severe architectural distortion or masses with irregular margins. But the key differentiation in this case will be that they are often bilateral and their symptoms follow a cyclical pattern, and they show less architectural distortion than breast cancer. So you can use these key differentiators to navigate through the dilemma of fibrocystic changes. When we come to sclerosing adenosis, it is a form of a benign proliferative fibrocystic change of the breast, characterized by an increased number of acini and their glands. It manifests as multiple small, firm, tender nodules, fibrous tissue, and variable microcysts within the breast. Sclerosing adenosis can appear as a focal or diffuse lesion. It is not physically palpable in 80% of the cases, although in some cases may cause skin retraction, but still it could not be palpable in most of the cases. It is sometimes placed under the category of borderline breast diseases. Here, a biopsy is required to confirm the diagnosis because the condition may be difficult to distinguish from breast cancer by imaging alone. And it could mimic invasive ductal carcinoma or ductal carcinoma in situ. The radiographic features of this suspicious mammographic imaging features of sclerosing adenosis could include amorphous, pleomorphic, or punctate calcifications. If a mass is seen as the presenting imaging feature, it can have irregular margins, although it is more commonly has circumscribed margins, but it could present with an irregular margin, thus raising the suspicion of breast cancer. Architectural distortion can also be an imaging feature of sclerosing adenosis. Sonographically, sclerosing adenosis can present as a circumscribed mass with a variable echogenicity. It can, however, mimic malignancy when presenting with suspicious features such as irregular mass or focal area of shadowing without a mass. Here we can see hypoechoic mass with irregular margins and the posterior acoustic shadowing in the first image. And in the second image, the patient presented with circumscribed hypoechoic mass with posterior acoustic enhancement. So it's a range of appearances. The mammogram here shows a mass with irregular to well-defined contours, architectural distortion, and microcalcification. And the ultrasound shows a mass with irregular border and posterior acoustic shadowing. We have a case here of a 35-year-old woman presented with a palpable breast mass. The mammogram did not show any abnormalities, but the gray scale and color Doppler ultrasound images revealed a vascular mixed cystic and solid mass correlating with the area of palpable abnormality. The core needle biopsy, when done, showed sclerosing adenosis in a background of dense fibrosis without atypia or carcinoma. The management of sclerosing adenosis ultimately relies on the imaging feature. So if the radiographic presentation is of a circumscribed mass or amorphous or punctate calcification in a grouped distribution with adequate sampling, a pathologic diagnosis of sclerosing adenosis can be considered concordant. If the imaging findings are more suspicious, such as an irregular mass or pleomorphic calcification in a segmental or linear distribution, a repeat biopsy is recommended. If you did it and they said that it is adenosis, you should repeat the biopsy to exclude coexisting malignancy or faulty sampling. If the sclerosing adenosis is associated with a radial scar, surgical excision is recommended in this case. In cases of well-sampled architectural distortion, a short-term follow-up is recommended. And then a short-term follow-up is also recommended for circumscribed masses to ensure their stability over time. Fat necrosis is a proliferative condition commonly seen as a result of saponification of local fat due to breast surgery, infection, trauma, or radiation. The fat necrosis comprises 2.75% of breast lesions and is initiated by the destruction of adipocytes, which causes an inflammatory process. The clinical feature of fat necrosis include palpable mass, pain, and skin changes such as skin tethering or thickening or dimpling. Most at risk are the middle-aged women with pendulous breasts or large breasts. The onset of the fat necrosis can be considerably delayed. It could happen even after 10 years of the trauma or surgery. Fat necrosis can have a very variable, sometimes alarming appearances on the mammogram, and is often potentially confusing to the non-expert breast imager. So initially, it can be seen as an ill-defined and irregular speculated mass-like area, and associated calcification can be present, which can mimic that of more malignant entities such as ductal carcinoma in situ. The calcification of fat necrosis is typically peripheral, with a stippled curvilinear appearance, creating the appearance of loosened bubble in the breast parenchyma. With time, it becomes more defined and well circumscribed, giving the rise of what we call oil cyst. Oil cysts can have very fine curvilinear calcifications of the walls. The center of the lesion becomes increasingly homogeneous with fat density. Breast ultrasound, acute phase within days of the trauma, shows increased echogenicity due to edema of the fatty tissue. And the subacute phase, which takes place between days to months, shows ill-defined complex cystic lesion. It could be unilocular or multilocular with low-level echoes surrounded by oedematous fat. And in the late phase, which could take up to one and a half year or even more, it shows calcified walls and as a consequence, posterior shadowing. If it is of post-surgical radiology, it can present with an angular margin or speculated mass with an echogenic rim, raising the suspicion for malignancy. Ultrasound of fat necrosis should always be interpreted in the context of mammographic finding. Aspiration of an oil cyst shows typically milky emulsified fat appearance. This is the typical appearance and is immediately recognizable. Suspicious mammographic features of fat necrosis that can closely mimic malignancy include irregular and speculated masses, architectural distortion, asymmetries, and coarse, heterogeneous, and even branching or polymorphic calcification. This could raise the suspicion for malignancy. Ultrasound features of fat necrosis that mimics malignancy include irregular hypoechoic masses with posterior acoustic shadowing. This is a serial mammography of a patient over the years, showing the formation of the calcification within the area of fat necrosis. This is another mammogram, shows large lobulated fat-containing mass-like lesion with coarse calcification seen at central portion of both breasts, right and left. This is the right breast. And a few smaller similar lesions are also scattered bilaterally. And this is the left breast. We have a case of a 52-year-old woman with remote history of mastopexy, presented with a palpable breast mass. Midulateral oblique mammogram shows an irregular mass with speculated margins. You can say irregular mass with speculated margins. Associated coarse rim calcification. Okay, and focal skin thickening. Longitudinal grayscale ultrasound shows a non-parallel irregular hypoechoic mass. And fast suppressed axial post-contrast T1 weighted image shows an irregular mass with speculated margins with associated signal void artifact related to post-biopsy clip marker. The ultrasound-guided biopsy showed that this is fat necrosis, and a repeat biopsy under MRI guidance confirmed the diagnosis of fat necrosis as well. Radial scar or complex sclerosing lesion is an idiopathic rosette-like proliferative breast lesion. It is not related to surgical scarring. A radial scar is a benign hyperplastic proliferative disease of the breast. Proposed possible cause in this situation includes localized inflammatory reaction and chronic ischemia with subsequent slow infarction taking place. Histopathologically, the radial scar contains hyperplastic tissue cells and a central fibrous core with a radial extension of tubular structures, giving it the speculated peripheral border. We were lucky to see a histopathologic image of the radial scar last week with Dr. Salwa. Significance is that it is a mimicker of serous breast carcinoma. The malignant potential is 2 times greater than that in normal population that does not have any radial scars. The reported prevalence of a radial scar is in the range of 0.1 to 2 per every 1,000 screening mammograms. Radial scars are very rare in women younger than 40 years and older than 60 years. So most patients or women will present between the age of 41 to 60 years. They are usually not palpable, and the clinical examination of the breast containing regions of radial scars is often normal, but 25% of the cases, they will be palpable. They do not cause skin thickening or retraction. Lesions are usually small and detected by mammography when they are at least like 5 millimeter in size. The lesions less than 1 centimeter are called radial scars, and the larger ones are often referred to as complex or radial sclerosing lesions. In mammography, a radial scar has a speculated appearance similar to carcinoma, but the center tends to be translucent here with low density area rather than a mass in the case of carcinoma, for example. The breast tissue behind the lesion is almost visible through the lesion. The relatively low density of the center is relevant and visible difference between the carcinoma. Structures which against a radiolucent fat background gives a black star or dark star appearance. Microcalcifications are possible but rare in a radial scar, but possible. Unlike a carcinoma, features such as skin thickening and retractions are characteristically absent. This image shows a well-defined density in the upper left quadrant, which was a cyst. And it also shows a speculated parenchymal distortion centrally with relative low density center and long speculated bands running concentrically from the center. In ultrasound, a radial scar is often ill-defined and disturbs the architecture of the surrounding breast parenchyma. The lesion is usually round, oval, or lobulated, and there is variable internal echoes can be found. Some radial scars show retroacoustic attenuation or shadowing. The differential consideration we need to put in mind in the case of the radial scar are breast cancer, where a central mass tends to form. The spicules are shorter and thicker in comparison to the radial scar, and there is retraction of the parenchyma, which is absent in the case of the radial scar. Invasive lobular carcinoma results in diffuse infiltration of the tumor cells and can sometimes be impossible to distinguish from a radial scar. In case another differential consideration is the post-surgical breast scar. In practice, this is rarely, if ever, a source of confusion. It is extremely rare to find post-surgical scarring with spicules as long as that of the radial scar. And you also have the history on the technologist note. And if all these measures fails, you can see the scar over the skin patients. It could give you a hint to the history the patient went through. A radial scar is considered a high-risk breast lesion, and histological differentiation from associated carcinoma is required. Fine needle aspiration and core biopsies can underestimate the underlying associated malignancy and are controversial in this case. Historically, if a radial scar was revealed on biopsy, surgical excision was always recommended due to the possibility of a sampling error caused by the eccentric and marginal location of an invasive cancer presenting within the radial scar. Nowadays, therapeutic excision with vacuum-assisted biopsy or excision is advised as the next step of management. Now we come to the benign tumors, which is the last group in our talk today. We are going to start with the hamartoma. The hamartoma, also known as fibroadenolipoma, are uncommon, slow-growing tumors that present or represents 4.8% of benign breast tumors. They typically occur in women older than 35 years of age, and they represent benign proliferation of fibrous, glandular, and fatty tissue, hence the name fibroadenolipoma, surrounded by thin capsule of connective tissue. All components are found in normal breast tissue, which is why the lesions are considered hamartomatous. It is often termed breast within a breast, also known as the salami tumor, due to the appearance of uncut section after the surgical excision. Breast hamartomas most commonly are asymptomatic or present as a painless soft tissue lump or soft breast lump. They may also present as unilateral breast enlargement without a palpable localized mass. Mammographically, a hamartoma has a characteristic benign appearance of fat-containing circumscribed mass. On ultrasound, a hamartoma presents as a parallel mass, circumscribed margins, and heterogeneous ecotexture due to variable amount of fat and glandular tissue. And although most hamartomas have a typical benign appearance, they can mimic circumscribed malignant tumors, such as the malignant phylloides tumor or breast sarcoma, if large, or when presenting with marked heterogeneous enhancement and irregularity. The appearance on breast imaging depends on the relative amount of fat and glandular tissue. In mammography, it is well circumscribed, round or oval mass surrounded by a thin capsule comprising of both fat and soft tissue internal densities. Fat component appears radiolucent, while soft tissue component appears radiodense. The classic description here is breast within breast, or a slice of sausage appearance, if you know what I'm talking about. The same thing, breast within breast, and a slice of sausage appearance. In ultrasound, because it resembles normal breast tissue, the margins are often difficult to delineate. It may be seen as a well-circumscribed solid lesion without any intralesional microcalcification. Internal ecotexture is most often mixed with both hyperechoic and hypoechoic components. Lesions are soft and easy to compress when performing the ultrasound. The same here. When we come to the pseudoangiomatous stromal hyperplasia, or PASH, PASH is a benign breast entity that presents with a wide spectrum of imaging features. It is characterized by proliferation of the fibrous stroma lined by a complex network of slit-like spaces and cylinder spindle cells. FASH is considered or associated with hormone exposure, including oral contraceptive use, and is primarily seen in premenopausal and perimenopausal women on hormone replacement therapy. It has been postulated that FASH may result from an abnormal reactivity of myofibroblasts to hormonal exposure, although the true etiology is still unclear. In mammogram, most often it is a circumscribed or partially circumscribed mass. However, they often present as an asymmetry or focal asymmetry, area of symmetry or focal asymmetry, and lesions typically lack calcification. In ultrasound, most often it is an oval or round circumscribed mass. It is often hypoechoic and may slightly be heterogeneous. Imaging appearance may be similar to that of a fibroadenoma. We have a case of a 41-year-old woman presented with a palpable breast mass. The mediolateral oblique mammogram shows a high density, well-circumscribed mass, and when the ultrasound was done, it showed a large oval circumscribed mass as well. The core needle biopsy showed pseudoangiomatous stromal hyperplasia. A different patient, a 40-year-old woman, was found to have a new breast mass on mammography, craniocaudal spot view. When the ultrasound was done, it showed corresponding oval isoechoic circumscribed mass in the area depicted by mammography. Core needle biopsy showed pseudoangiomatous stromal hyperplasia or PASH. Although it can coexist with malignant lesions, pseudoangiomatous stromal hyperplasia itself is a benign entity without an increased risk of malignancy by itself. Up to date, only one single case of PASH with malignant transformation has been reported in the literature. In cases where PASH is identified as an incidental finding on pathology, no additional intervention is necessary, and clinical and imaging follow-up is recommended in this case. But when PASH is identified as a mass on imaging or in the targeted lesion on biopsy, then surgical excision can be considered for larger lesions that is more than 2 centimeters, and for women with an increased risk of developing breast cancer or strong family history. In the presence of an enlarging mass, surgical excision is recommended. Recurrence after excision of PASH has been reported at rates of ranging between 5 and 22% of times. That was all about PASH. When we come to fibroadenoma, we know that fibroadenoma is common benign. Please mute yourself, Dr. Anusa. Please mute yourself. Fibroadenoma is a common benign breast lesion resulting from excessive proliferation of connective tissue. And the typical presentation is in a woman of reproductive age with a mobile palpable breast mass. Due to their hormonal sensitivity, fibroadenomas commonly enlarge during pregnancy and involute at the menopause. Hence, it is very rare to present after the age of 40 or 45 years of age. The lesions are well defined and well circumscribed clinically with normal overlying skin, and they are not fixed to the surrounding parenchyma, and they slide around with palpation, hence the name the breast mouse. Although they can be located anywhere for breast, they have a predilection to the upper outer quadrant. This regarding the mammographic features of the fibroadenoma have a spectrum of features, from well circumscribed discrete oval mass or hypo or isodense to the breast glandular tissue, to a mass with a macro lobulation or potentially or partially obscured margins. Involuting fibroadenomas in mammography in older patients, typically the patients of postmenopausal period may contain calcifications, often producing the classic coarse popcorn calcification of fibroadenoma. In some cases, the whole lesion could be calcified. Calcification may also present as a crushed stone-like microcalcification, which makes differentiation from malignancy difficult in this case. An image of the fibroadenoma, well-defined, hyperdense breast mass in both images. This is an image of bilateral breasts showing involuted fibroadenomas. There is patchy and dense asymmetric fibroglandular tissue in both breasts. There are several potentially observed masses of different sizes seen at these images. Some of them show calcification, mostly in the entire mass, representing evoluting fibroadenomas. In ultrasound, typically, they are seen as well circumscribed, round, or to avoid or macrolobulated mass with generally uniform hypoechogenicity. Intralesional sonographically detectable calcification may be seen in around 10% of the cases. Sometimes a thin echogenic rim or pseudocapsule may be seen. And this is another ultrasound showing lobulated, sharply demarcated hypoechoic mass with a thin echogenic rim or pseudocapsule with posterior acoustic enhancement. These lesions are easily biopsied under the ultrasound guidance, and when a lesion has the typical features of a fibroadenoma on ultrasound and there are no clinical red flags or suspicion regarding this mass, they can be safely followed up clinically. When lesions are enlarged or have atypical imaging findings, ultrasound-guided core biopsy is a minimally invasive outpatient procedure that could be done easily. That will help give a diagnosis with virtually no complications post-procedure. Depending on where you work, there may be a maximum diameter above which a biopsy should be done automatically if no previous imaging is available to compare the interval growth of the mass. And there is significant local variation in this regard. The reason for intervention based on size is that a phylloidous tumor is indistinguishable from fibroadenoma on ultrasound, and it could be from the malignant subtype, for example. A maximum diameter of 2.5 centimeter may be useful benchmark for biopsy if you have no previous imaging to compare with. The interval enlargement is an indication for biopsy. On a mammogram, fibroadenomas with evolving calcifications may show microcalcifications, punctate, linear, or polymorphic, which can make differentiation from malignancy difficult. In such cases, fibroadenoma can be considered only if these calcifications are found within a circumscribed mass or at least one additional shell-like calcification is present. Otherwise, a biopsy is a must. These are images to show the importance of follow-up in the case of fibroadenoma. This was a benign fibroadenoma until recently started to develop some ductal carcinoma in situ at the margins of the fibroadenoma. So you need always to follow up your patient. The last thing is the phylloidous tumor. Phylloidous tumor or sarcoma phylloides are rare fibroepithelial tumor of the breast that have some resemblance to the fibroadenoma. They are typically large, fast-growing mass that forms from the preductal stroma of the breast. Phylloidous tumors account for less than 0.3 to 1% of all breast neoplasms, and it is predominantly a tumor of adult women, with very few examples or cases found or reported in the adolescents. The occurrence is most common between the ages of 40 to 60. Before menopause, the peak incidence is around 45 years. This is about 15 years older than the typical age where the patient presents with fibroadenoma. So you could use the age here like a discriminator factor between phylloidous tumor and fibroadenoma. Patients typically present with a painless, rapid growing breast mass for which imaging is requested. Average size can vary anywhere from 3 to 5 centimeters at presentation or even more. Phylloidous tumor can be considered benign, borderline, or malignant, depending on the histologic features, including stromal cellularity, infiltration at the tumor edges, and mitotic activity. At histologic analysis, the tumor can resemble a giant fibroadenoma with both epithelial and stromal components being seen. Fine needle aspiration is inaccurate here, and even core biopsy has moderate sensitivity due to the tumor heterogeneity causing inadequate sampling. So you could take the sample from an area of that does not show the malignant potential or malignant transformation. The tumors can be quite large at presentation. Imaging alone is not adequate to differentiate phylloidous tumor from fibroadenoma, and phylloidous tumors are frequently classified as BioRad4 tumor. Biopsy is of importance in this case. In mammography, phylloidous tumor are typically seen as non-specific, large, rounded, or oval lobulated mass. They are generally well-circumscribed lesions with smooth margins. They have radiolucent halo, sometimes present. Calcification, typically coarse and Blake-like, may be seen in a very small proportion of patients. In ultrasound, the general sonographic features are non-specific and can mimic that of a fibroadenoma. And inhomogeneous solid appearing mass is the most common manifestation here. A solid mass containing single or multiple round or cleft-like cystic spaces and demonstrating posterior acoustic enhancement strongly suggest the diagnosis of phylloidous tumor. Vascularization is usually present in the solid component, as in this case. In practice, most lesions are indistinguishable from fibroadenomas on both mammography and ultrasound. This is why interval enlargement of fibroadenoma is seen as an indication of needle biopsy. Large lesions, which are more than 4 centimeters, may qualify for excision out of hand because a needle biopsy may not be representative of the pathology in the whole lesion. It is a locally invasive tumor. Treatment is usually with surgical excision. Large tumors may even require full mastectomy sometimes. Both benign and malignant phylloidous tumors have a tendency to recur if not widely excised. So the excision is always with wide excision margin. Malignant degeneration is seen in 5 to 25% of patients, and malignant phylloidous tumors are called this in this case. After a wide local excision, there is relatively frequent local recurrence, up to 25%, and up to 10% of them can metastasize. The mode of metastasis in such cases will be hematogenous. We are going to talk briefly about the advances in breast imaging that will help, and it is helping actually currently to make a clear cut between the benign and malignant conditions and help reducing the dilemma or mistakes. We are going to talk first about the digital breast tomosynthesis or 3D mammography. The advancement in breast cancer detection technology have significantly improved the ability to distinguish between benign and malignant conditions, reducing the risks of misdiagnosis. Digital breast tomosynthesis, also known as 3D mammography, creates detailed three-dimensional images of the breast by taking multiple X-ray images from different angles. So it reduces the overlap of dense tissue that can obscure tumors in the old known 2D mammograms, leading to fewer false positive and negatives. It helps in better visualization of the overlapping structures, making it easier to differentiate between benign and malignant masses. Dr. Muhammad, please mute yourself. Dr. Muhammad, please mute yourself. Improved accuracy in detecting small tumors, especially in women with dense breast tissue. And this is an image of 3D mammography that shows an excellent view of very small, tiny calcifications seen with very high resolution. The contrast-enhanced mammography involves injecting a contrast agent into the bloodstream, which highlights areas of breast that may be suspicious for cancer. The images are then captured using the standard mammography 2D. It enhances the sensitivity of mammography, especially in women with dense breast tissues. It allows for more accurate assessment of both benign and malignant lesions and improving the differentiation between the two. It is a quicker and more cost-effective alternative for breast MRI with all the waiting time and long lists for MRI with similar accuracy in some cases. This is a case of contrast-enhanced mammography. When we come to the breast magnetic resonance imaging, or MRI, breast MRI uses powerful magnets and radio waves to create detailed images of the breast tissue. When combined with a contrast agent, MRI can provide high-resolution images revealing tumors or abnormalities very well. It provides superior soft tissue contrast and sensitivity, which is especially helpful for distinguishing between benign and malignant lesions in dense breast or when there is a dilemma between both. MRI can differentiate benign conditions like cysts, fibroadenomas, and fat necrosis from malignant tumors based on their different enhancement patterns after contrast administration. It reduces the risk of false positives, as benign lesions typically show a different enhancement pattern than the malignant tissues. Ultrasound elastography, the king of all. This technique measures the stiffness of the breast tissue using ultrasound waves. It is based that the cancerous tissues are usually stiffer than benign tissues, so the technology can quantify the tissue hardness and helps in diagnosing malignancy based on the tissue hardness. It helps distinguish between benign and malignant masses by assessing the stiffness of the tissue, and it reduces the need for unnecessary biopsies in benign cases. It can be used as an aid to standard ultrasound for better risk stratification of breast lesions. This is an image showing an elastography where the mass is given colors, different color ranges based on its stiffness. Lastly, the artificial intelligence and machine learning algorithms. AI and machine learning algorithms are now being integrated into breast imaging systems to analyze mammograms, ultrasounds, and even MRIs. These algorithms can automatically detect, classify, and assess breast lesions based on patterns learned from large data sets or databases. Enhances the accuracy of mammography and other imaging modalities by identifying subtle patterns that might be missed by the radiologist. Actually, in this case, an expert radiologist. It reduces human error and helps in early detection of suspicious lesions, thereby minimizing false positive and false negatives. It helps differentiate between benign and malignant lesions by analyzing image features such as the shape, size, texture, and contrast uptake. And some AI modules are trained to identify specific conditions such as fibroadenomas, cysts, and malignancies, making the differentiation process more efficient and reliable. In Sudan عندنا تجربة جديدة بيعملها باشمهندس محمد عبد الله نصر. البروجرام حقه اسمه ميلاد. It's an AI generated program that reads or based on a large database or data set of information that enables the program to detect the masses and classify them into benign, malignant, or borderline. It is a very important breakthrough that is under development now. We are so pleased to have such a breakthrough in Sudan by a Sudanese engineer, and inshallah, we hope the best for him in the coming times. Thank you very much for your attendance, and if there's any question you would like to ask, I'm here to answer.
Before asking, it is really an amazing and informative lecture, Dr. Nawras.
Thank you so much يا بروف. Thank you.
ما شاء الله ما شاء الله، يعني بجد enjoyable.
نستفيد منك يا بوس.
لا استمتعنا يعني well done.
تسلمي.
well done.
كتر خيرك. تسلمي من ذوقك.
فخورة جدا الآن، فخورة بك خالص والله.
يديك العافية يا بوس. ده ماشيين على خطاكي.
لا ده الحوار الغلب شيخه.
ولا أبدا، العين ما تعلى على الحاجب.
الله يكرمك يا رب.
أنا
يوفقك.
بضم صوتي لدكتور رباب صراحة، يعني بضم صوتي للبوست دكتورة رباب، يعني سيشن
يديك
رائع و very
العافية.
beneficial.
Thank you so much من ذوقك. بس معليش صوتي كعب الليلة، صايمة ورجلي ناشف، فمعليش اعذر.
ما لاحظنا.
يديكم العافية.
تمام ما شاء الله. الليكشر went perfect.
Thank you so much يا بوس. Thank you من ذوقك.
May I just comment that in Sudan we are seeing, I think Rabab will say the same, and all of you working. In Sudan we have phylloides that is much, that comes in younger patients.
دكتورة نادية.
أيوة.
ما كان واضح
كيفك؟
شديد.
صوتك بعيد شوية يا بوس.
in Sudan الفيلويدس بيجينا في ناس younger patients.
أيوة.
يعني we have to think of phylloides مش أنت قلتي 40 to 60 year age.
You are right.
لكن in Sudan it's younger.
حتى outside Sudan أنا لاقتني كيسز كثيرة، يعني حتى في لما شغلي برا كان لاقتني فيلويدس في ناس ينج، عرفتي؟ لكن على قولتك هو في السودان فعلا في فيلويدس in young age group. yeah. we have to consider، يعني نحن ما نقول إن البيشنت younger than 40 this is typical fibroadenoma. No, we have to put also we have to put phylloides in our mind
as a possibility.
خاصة إنه الكومبلكس فايبروادينوما هي بتدخل differential مع الفيلويدز أكتر، لأنه الكومبلكس فايبروادينوما بيكون فيها cystic changes، والفيلويدز بيكون فيها clefts or cystic changes. this is for biopsy، يعني حتى اللي هي الكومبلكس فايبروادينوما it is for biopsy. بيرات 4 is not a بيرات 3، والفيلويدز is بيرات 4. it has to be biopsied. بعدين في حاجة تانية، إنه في الفيلويدز طبعا عارفين إنه عندنا benign فيلويدز وعندنا intermediate وعندنا التيبيكال مالجنانت أو الانdeterminate أو الانترميديت، حاجة زي ديت. وفي تاني المالجنانت
البوردر لاين.
بفتش للبوردر لاين دي، هي البوردر لاين وليس انترميديت، هي benign وبوردر لاين ومالجنانت. فالثلاثة الايميجينج unpredictable. ممكن تكون benign by imaging suspicious وتطلع benign فيلويدس، وممكن تكون imaging wise appearing having a benign typical benign feature وتطلع frank malignant phyllodes.
مم.
وطبعا احنا في اللاب برضو الشغل بتاعها can be very difficult في انه we have to take extensive sampling of the specimen.
You have to take what?
extensive
extensive
sampling
sample.
ايوه لانه مرات بتكون ميكس صح. هي حتى فايبرو ادينوما معاه فيلويدز.
غير
مم.
كده حتى عشان to determine what grade of phylloides it is, you have to take so many blocks and go back
مم.
correlate with radiology and patient والمارجن طبعا
So
السيرجنز
in this case,
مشكلتهم
excisional biopsy would be more
yes
beneficial. Mm.
yeah and the thing is that
probably
if
here,
they
sorry.
grow very quickly
Yeah.
very quickly and
Mm.
so the patients come with huge masses that is difficult to do a good margin and the margin has to be big surgically it has to have أنا ما متأكدة لكن it has to be a big margin. It's not like in tumors.
Wide margin eye.
Yeah.
Wide excisional margin.
عشان كده انا دايره اقول لها هنا الاكسجينال باوبسي is not يعني ما هو الطريقه اللي بيتعاملوا بها مع الفيلويدز. لانه they need to know before surgery is it just a fibroadenoma or phylloides عشان هل يعملوا just excision of the lump or to do wide local excision. لأنه
Exactly.
they will go for wide local excision. إذا fibroadenoma just they are going to excise the lump. فبكونوا عايزين قبل السيرجري وهم داخلين يكونوا عارفين إنه هم داخلين عليه فيلويدز ولا
طبعا yes.
ولا fibroadenoma. وهي growing yes it is rapidly growing. وتريكيرس يعني زي ما انت تفضلتي في حتى البيناين فيها ريكرنس. البيناين والبوردر لاين فيه ريكرنس لكن اقل من المالجنانت. كان 25% كان كم يا انا ما متذكره كان في حاجه واحده فيهم 25% اظن البيناين صح؟
اي
البيناين 25% التريكيرس والمالجنانت much more.
لكن ده عشان الانكمبليت اكسجين.
اي
لا it behaves حتى غير في incomplete oxygen ما أعرف
حتى مع الوايت لوكال اكسجين
حتى مرات مع الوايت لوكال oxygen بيحصل recurrence yes and I have seen يعني some cases حتى مع الوايت لوكال يعني they treat الكيس as phylloides not as fibroadenoma وبرضه بتجينا بريكارنس.
اوكي
برضه بتجي بريكارنس. وشفت كيس كانت يانج كانوا يعني كم 20 سنة في السودان وعملوا لها كانت malignant phylloides وعملوا لها extensive surgery حتى ما دخلوا فيها thoracic surgery شنو حصل لها recurrence 3 times. بعد الثيرد تايم ده يعني invade the chest wall ودخلت البلورة واللنج وكده.
لا حول ولا قوة الا بالله.
يعني within short period كانت وكان عمرها كم 20 سنة.
لا حول ولا قوة الا بالله. This proves حسي كلام الدكتورة نادية والدكتورة كلامي كلامك.
ايوه انا ما قلت لها كده. ايوه كان وحتى لما بمناسبة الكيس دي عرفت انه في كان تاني يعني multiple cases like that. ف we have to think about it يعني ما بس ناخد انه الايج فاكتور لا even in ladies we have
This
to think
also proves الملاحظة حقتك يا بوس بتاعت انه الكانسر distribution في السودان happens in younger ages انه عندنا الحكاية مختلفة.
ايوه حتى الساركوما والفيلويدز دي داخله في الساركوما جروب. حتى الساركوما هنا يعني غير عن الابيثيليال بريست كانسر. حتى الفيلويدز المالجنان فيلويدز عندنا اكثر. Any more comments or question?
We have no surgeons today.
الليلة ما في surgeons هاي.
كان أكيد سألوا.
هاي. أو كانوا برضو حيعلقوا لنا على حكاية السيرجيكال انبوت في
أيوة.
الموضوع ده. كانوا
Definitely.
ادونا انسايت حلو. Thank
أيوة.
you so much everybody for attending.
Thank you.
I hope that you benefited the most from this presentation, and we wish to see you all soon in the coming presentation next week, 6 p.m. Sudan local time, inshallah. Thank you very much, and see you soon.
With
Thank you.
Dr. Aida, yes, Dr. Aida, Dr. Nahla, and Dr. Wala.
أيوة.
Next week.
إن شاء الله. الإعلان حينزل في كل الجروبات بالتايمينج والتايتل of the webinar إن شاء الله.
Inshallah.
Thank you very much.
Thank you.
Thank you. Thank you all.